Namaskar, dear viewers. Welcome to today's session of Critical Care webinars. And today we have a very important topic, envenomations. So we're going to be discussing snake bites as well as scorpion bites. And we have included scorpion bites because though they are rare and not so common, but it's a very big problem when you get a scorpion bite because people are not well versed with how to manage, and it can be very catastrophic because there are severe changes, hemodynamic changes in scorpion bite. And of course, snake bite, you are somewhat well versed because that is taught commonly and you see snake bites. So today the discussant and the speaker is Dr. Leelawati Thakur ma'am. She is consultant at she's a consultant in critical care at Mission Hospital, Durgapur, and she has a vast experience in handling such cases. And she has been the eminent faculty member of a Young India intensivist. So that was about the lecture. Other thing I would like to tell everybody is that we shall be taking forward our Young India Intensivist Forum and forming a society. So the society shall have multifaceted tools, including a vibrant website and many other things it will offer to all its members. So soon in the coming months, we shall form the society. It's in the process of getting registered, etc. formalities. And I strongly encourage all of you join it because it will be very helpful to you, because this is only webinars that we are doing. But once we form a society, there will be many other things and many other educational tools that will be offered to you. And the society will be called, in all probability, Academic and Research Intensive Care Society of India with the acronym ARICC. So just to update you guys. Okay, ma'am, over to you.
Thank you, Dr. Tapesh, for a wonderful introduction. Hello, good evening all. And so we now start about all the envenomations. Actually, envenomation will encompass snake, scorpion, as well as bee, hornets and all. But I'm going to limit my talk within this with the snake and scorpion only for today. So let me share my screen. Is it visible,
Yes, ma'am.
Dr. Tapesh?
Yes, nicely visible.
Okay. So we start it right now. Actually, in my experience, we have come across many snake bites when I was in Kolkata earlier. So we used to see all the hematotoxic and vasculotoxic snake bites. Whereas whenever I was in North, like Delhi and Gurgaon, those times I have seen mostly the neurotoxic ones. So the distribution of the snakes are like that only. More than 2 lakh snake bites are reported in our country over a year, and estimated 35 to 50,000 people die each year from snake bites, which are actually, many of them actually are not accounted for because they die near the ojhas and traditional healers and all. So we are going to discuss about what to do, what not to do, and how to care for a snake envenomation and or a scorpion envenomation. So coming to the snake first, the reptiles actually, the phylum Chordata, Vertebrata, Reptilia, Squamata, then Serpentis. The serpentine families are Colubridae, Elapidae, Hydrophidae, Viperidae. And if you see really, they're actually Colubridae, Elapidae, and Viperidae. From Elapidae, there are two families, Elapini and Hydrophini, which are consisting of our Indian snakes. So coming to our Indian varieties of snakes, there are 216 species of snakes in India, out of which 52 are venomous. And these are the common snakes that we come across in India. There are Elapidae, mostly Elapidae and Viperidae. The sea snakes and all, those are myotoxic, and those are not really or regularly come across. So we are going to limit our discussion within this Elapidae and Viperidae only. So Elapidae are cobras, kraits. These are the main things. And from Viperidae, the Russell's viper, the sawscale viper, the hump-nosed pit viper, Indian bamboo viper. Out of this hump-nosed pit viper or any pit vipers, actually bamboo viper is also a pit viper. Those are generally, we do not find any ASV for them. So that is why these are very, very dangerous. Now, coming to next is the 30 most venomous snakes in the world. In world, there are much more toxic snakes than India actually exist. So there are many which I have shown over here. The taipan, the Dubois sea snake, eastern brown snake, yellow-bellied sea snakes. These are very, very dangerous. So the syndromes that snake bite, snake venoms actually envenomation cause is neurotoxic, hematotoxic, and cytotoxic. So neurotoxic, there are mild, moderate, and severe symptoms. For mild, this is local paresthesia and neuropathic pain, piloerection, and muscle spasm, fasciculations. These are all mild neurotoxic syndrome. But moderate will be bilateral ptosis, starts from bilateral ptosis, and we are going to discuss in great details in next few slides. Visual, auditory, other sensory disturbances or widespread hyperesthesia, these are all coming under the moderate one. And severe is speech disability, swallowing disability, difficult breathing. These are all severe, come under the severe classification of neurotoxic syndrome. And hemotoxic, mild is coagulopathy, persistent local bleeding from the bite wound. And moderate systemic bleeding comes under moderate, gingival bleeding, epistaxis. Even I have found some patients, particularly young patients, come from local near about Kolkata. They come with their tears are consisting of blood only. I have seen those. These are all moderate symptoms, and in severe there is active GI bleed or any other internal bleeding, including the intercerebral bleed also. And definitely that will cause altered mental status. And in cytotoxic syndrome, there are mild will be severe pain, edema, swelling of the body part which is bitten actually, and edema below elbow or knee, that will be a limited one or a mild one. But moderate will show it will be going beyond the next joint or the elbow or knee, but not beyond shoulder or hip. And progressive edema beyond shoulder or hip, severe necrosis, widespread blistering, and these are all coming under severe cytotoxic syndrome. So next, coming to the how to identify the non-venomous from venomous one. The non-venomous snakes, they have got kind of stocky teeth. They do not have fang. So generally this will be a kind of a abrasion mark whenever the snake bites. And venomous generally have the fangs, and two fang marks, sometimes one fang mark also can be present. And there are different in the difference in the scale and all. You can see here, from here, there are different types of scale in the non-venomous one. There are two scales in the tail, whereas there is single scaling in the tail of the venomous one. And about these heads, the rounded head is a non-venomous one, and a triangular shaped head is a venomous one. So these are all, and like for the rattlesnake, the tail is a little more pointed one, whereas this for the uh, non-venomous one, this is not so pointed. And you can see the difference in the abrasion kind of, or fang marks. So again, tail, belly scales, head scales, vertebrae, there are all different types of scaling and vertebrae placement. Like tail is laterally compressed, is a poisonous one. Tail cylindrical tapering, though both poisonous and non-poisonous, but mostly poisonous one. Belly scales, small, continuous with the dorsal, are non-poisonous one. And ventrals are fully broad cover belly, non-poisonous one. Ventrals broad, fully covering belly, mostly in pythons. Laurial pit and subcaudal single, these are found in the head. So head scale small, head triangular is always a poisonous one. That is pitless vipers and pit vipers both. Head scale small, laurial pit present between the nostril and the eye. Those are particularly characteristic of pit vipers. Those are very poisonous. Head with large shields. There are some snakes who have got large shields. Vertebral fourth infralabial, third supralabial scales and vertebrae. These are hexagonal in poisonous. And mostly, and no such characters will be non-poisonous. You can see the placement of the scales like this in poisonous snakes. These are all poisonous snakes, the big fours. The earlier one was a cobra, this is a crate, and this one is a Russell's viper. This is another pit viper. This is a spectacled cobra. This is very, very common in West Bengal, actually. Southern part of West Bengal, and there are monocled cobras, which are Kauthia. Monocled means that is Naja Kauthia. That is available in northern of the Bengal, West Bengal. And this one is a banded crate. Those are found in northern side of our India, mostly in drier drier forests. So these snakes actually they have disappeared from West Bengal because they are actually, the food of these snakes are Russell's viper. So these snakes feed on snakes, and that is why the Russell's viper are now coming more in number in West Bengal side, because these banded crates and crates are actually disappearing from here. This is again bamboo pit viper, very poisonous. This is another part of like pit viper. These are all different. You can see the beauty of the scaling of the snakes in those pictures. So these are the common venomous snakes which we have. Now, World Snake Day. I think many do not know that there is a World Snake Day. Yeah. That's on 16th of July, when we should know the big four, which I'm going to discuss about, all those, because they are the commonest venomous snakes in India. Indian cobra, Naja naja, saw-scaled viper, Echis carinatus, common crate, Bangaras, and Russell viper is there. So severity and outcome I'm going to tell in later on. So whenever you suspect a snake bite, the overt bite, you can see the history of bite. If the non-venomous are mostly 70%. So whenever a victim is get bitten by a snake, most of the time it is a non-venomous, and generally the victim gets frightened and get a sympathetic surge, and that is why they may have some symptoms that I am going to tell you. So venomous is 30%. Out of those 30%, again, dry bite is almost 50 to 80%. So mostly the snakes are not so harmful, you see. Anxiety, palpitations, tachycardia, paresthesia, these are the major symptoms of dry bite as well as the asymptomatic bite. And symptomatic bite, predominant symptoms are these four, whatever we have already discussed. The progressive painful swelling, neuroparalytic, vasculotoxic, and myotoxic. And there are some cases where there is a occult bite, particularly with the crate. And with the crate, actually crate are very much in, they actually like the smell of the sweat of human being. And whenever they come in contact with this thing, they just slid in the bed of the human being, and they lie down there. And whenever the person just moves and all, they bite. The crate gets a little frightened and bite. So here, many a times I have seen one case whenever I was in Gurgaon, one young lady, 25 years old, she came with a history of snake bite, and definitely she was gradually getting her this thing, ptosis and swallowing difficulty, dysphagia, drooling, and as well as later on she was developing respiratory muscle paralysis, and then that time she had come to us, but there was no fang marks. So people thought that it's must be a, I mean, mimic kind of a thing. Actually, for crate bite, please take it seriously. And whenever you see ptosis, please go in for ASV. So neuroparalytic symptoms with no local signs almost. The asymptomatics will be mostly from a non-venomous species. The bite is from a venomous species, but not injected enough venom to cause symptoms. That is a dry bite. And the venom is of sufficiently high level to cause symptoms, but is now progressing through the tissue to cause a swelling to indicate its presence. Envenomation can take many hours. So in those hours, patient may be asymptomatic. The victim may be envenomed, but no visible signs or immediately detectable symptoms like crate. Now, what are the stages of management as per the WHO? The first aid treatment, then transport to hospital, rapid clinical assessment and resuscitation, investigation, laboratory test, clinical assessment and species diagnosis, if possible. If the person has seen that snake and can describe, then antivenom treatment, observing the response to antivenom, deciding whether the further dose or some adjuvant treatment is needed, then supportive or ancillary treatment, treatment of the bitten part, and then follow-up and rehabilitation. These are the components of stages of management. So first aid, do it right. Right means reassure, immobilize, get to hospital, telltale signs. So these need to be taken care at the time whenever the patient is just being seen by a local people, the relatives and the near about ones. No tourniquets. These are to be followed very, very strictly. So no tourniquets. Why not tourniquets? Whenever you put a tourniquet, actually we try to limit the venous drainage and all. But if the tourniquet is so tight enough that the arterial circulation gets also hampered, then we are going to lose that limb. So we need to give no tourniquet and immobilize the portion of the body. So attempt to retard systemic absorption of venom by immobilization. Preserve life and prevent complication before the patient can receive the medical care. So aim to do no harm to the patient. At the community level, what the people can do. This is a very, very pertinent discussion we need to know, and we need to spread the awareness about, is that check history of the snake bite, look for obvious evidence of bite, fang puncture marks or bleeding or swelling of the bitten part. And remember that crate bite, no local marks may be seen. Reassure the patient. Around 70% of all snake bites are non-venomous species, so person should be reassured. Immobilize the limb in the same way as a fractured limb. If the person gets a fracture, the limb are immobilized so that no joint from the proximal side or the distal side can move. So as a fractured limb we we have to immobilize that limb. Use bandages or cloth to hold the splint. Wooden stick, or if the bite is in one leg, the another leg can be used as a splint for the opposite leg. And just wrap that, I mean, this thing, the piece of cloth and all, and but do not block the blood supply or arterial supply. Patient should lie in the recovery position, prone on the left side, with the airway protected. Shift the victim to the nearest health facility as soon as possible. The limit, whatever I have studied, is 30 minutes is the limit within which the person needs to reach a primary health center or a hospital. Arrange transport of the patient or medical care as quickly as possible, safely and passively as possible. The patient should not move himself. Somebody has to carry him like plank to the hospital, or by vehicle, ambulance, boat, bicycle, motorbike, stretcher, whatever. So traditional remedies should not be applied at this. They have no proven benefit in treating snake bite. They do more harm. So this is how the immobilization of a limb should be done. And faster transfer to the healthcare facility. Victim must not run or drive himself to a health facility. Please remember this. Motorbike ambulance may be a feasible alternative for rural India. In PHC, the medical officer can accompany with the patient to know the progress and management to facilitate resuscitation on the way. And doctors, we need to inform the doctors about any symptom that we are coming across, like progressive swelling and ptosis or new symptoms that patient can tell. And this is a must, is that remove the shoes, rings, watches, jewelry, because if the limb is becoming progressively swelling up, then these are actually acting as a tourniquet. The rings, watches, jewelry, and tight clothing, these are going to act as tourniquet only. So we have to remove those as soon as possible and leave the blisters undisturbed. Do not prick them. Dry bite is again 10 to 80% of various poisonous snakes we see that there are dry bites. May develop quite striking symptoms because of the sympathetic symptoms, mostly due to the anxiety. Now, what are snake venoms made of? Those are cytokine mediators, addition molecules, and mostly the enzymes. There are all cocktail of many enzymes like polynucleotide toxins, non-toxic proteins, carbohydrates, metals, lipids, free amino acids, nucleotides, amines. There are many things. Phospholipase A2 mostly. Those are hemolytic and myelolytic phospholipases. So the fact is that every snake has got all kinds of toxins in them, but in some snakes, like in neurotoxics, mostly the cholinesterase, they play a upper hand, whereas in the rhesus viper or the vasculotoxic or hemotoxic, the others, like phospholipase A2, they play around. So neurotoxic portion is less in that Russell viper, whereas in crate, the neurotoxic part, the neurotoxins are much more. So these are the things which, with direct injury, they can cause hemolysis, myonecrosis, intravascular coagulation, hemorrhage, vasculitis. These are the things. And immune response can cause, the snake venom is again a protein, so patient may have an immune response, and they can cause a glomerulonephritis, interstitial nephritis, and tubular necrosis, cortical necrosis. Many things actually are seen. The composition I have already discussed, that phospholipase A2, phospholipase B, phospholipase C, lactate dehydrogenase, phosphomonoesterase, phosphodiesterase, acetylcholinesterase, RNase, DNase, 5-nucleotidase. These are the things. And more lethal venom fraction of snake venom appear to be certain non-enzymatic proteins also, as well as some heavy metals. There are heavy metals in the snake venom. So whatever I have told you, that elapid venoms are rich in acetylcholinesterase. So mostly elapid snakes are neurotoxic. The systemic effects of venom, these are the systemic effects. You can see the hemostatic alteration, the myocardial damage, acute kidney injury, local tissue damage, neuromuscular paralysis, systemic hemorrhage, and leading to a cardiovascular shock, generalized myotoxicity by the sea snakes induced by the phospholipase A2. Now coming to the symptoms. Neuroparalytic or elapid envenomation generally come with the neuroparalytic symptoms like progressive weakness and elapid. Elapid is a neurotoxic one. So patients present with the typical symptoms within 30 minutes to 6 hours. You can see there is a progressive increase in the symptoms. They present within 30 minutes, maybe within 30 minutes, or can delay at up to 6 hours in case of cobra bite, and 6 to 24 hours for crate bite. However, ptosis in crate bite have been recorded as late as 36 hours too. So we can see that crate bite also can actually present in later date. So these symptoms can be remembered as 5Ds and 2Ps. What are the 5Ds? Those are dyspnea, dysphonia, dysarthria, diplopia, dysphagia. And 2Ps are ptosis and paralysis. And here in this picture, you can see the ptosis. This ptosis is now increasing along with some local swellings. And you can see the patient can see, but whenever the ptosis is so much deep, you need to literally pick this eyelid up. Otherwise, patient cannot see. So you can see this is a crate again, but this is a banded crate. What are the symptoms? So furrowing of the forehead, ptosis is the first symptom that occurs. Then diplopia, dysarthria, dysphonia, dyspnea, dysphagia, descending neuroparalysis. This is descending neuroparalysis. Everyone has to remember this. It starts from head to toe. So all these symptoms are related with third, fourth, sixth, and lower cranial nerve paralysis. Finally, paralysis of intercostal and skeletal muscle. This is the final, nail in the coffin. You can say that paralysis of the intercostal muscles and skeletal muscles occur, and patient go into respiratory paralysis. So respiratory failure, impending respiratory failure, you can identify with single breath count. Number of digits counted in one exhalation is more than 30 is normal, but less than 30 you can say that it's actually there is some kind of respiratory paralysis is happening. And breath holding time should be more than 45 seconds. And if it is less than 45 seconds, again, you can see that there is a respiratory paralysis happening. Additional symptoms are absent deep tendon reflexes and head lag. That is, this head lag is called broken head. I could have actually given you the exact video that we have caught on the camera, but I couldn't actually remove the identifications, so I didn't put it here. So there is a head lag that is called a broken neck syndrome. Additional features like stridor ataxia that can happen, drooling also, because patient can have dysphagia, so there are droolings. Associated hypertension and tachycardia may be present due to hypoxia. But remember, this is very, very important, is bilaterally dilated, poorly or non-reacting pupil is never the sign of brain dead in elapid envenoming. If there is a history of elapid envenoming and the patient is bilaterally dilated pupil, which is not reacting to light, please do not leave hope. I had this kind of a patient who actually needed 2 weeks to come out from this neurotoxin. 2 weeks. Everybody had loosened hope and almost on the verge of telling it that patient is not going to come out. That time patient suddenly started flicker of movement in his upper limbs. So, lower limbs. So again, whenever the movement comes, this starts from the lower towards the up and ptosis goes the last. This is very, very important because the comeback of the power comes in ascending manner. So this is very important that bilaterally dilated pupil should not be taken for granted that patient is bended in a elapid envenoming. So there are few this thing neurotoxic snakes that cobra, crate, Russell's. There are the Russell's viper also have some neurotoxic effect. Mamba and this rattlesnake. These are also very much well known for their neurotoxic symptoms. So here we need to see mostly the elapids, they have both pre and post synaptic blockage. Whereas the viper, Russell viper, they have most presynaptic blockage. So both presynaptic and postsynaptic blockages are actually happening in neurotoxic bites. And in rattlesnake, this is mostly the presynaptic. You can see this happens. Mostly by acetylcholinesterase. You can see in the post synapse, there are depolarized postsynaptic membrane that causes the flaccid paralysis. Here, succinylcholine, like this happens like succinylcholine only. Now coming to the vasculotoxic or hemotoxic or bleeding, the local manifestations prominent in Russell's viper, followed by saw-scaled viper. So Russell's viper is very, very common in our southern part of the West Bengal also. We see mostly the Russell's viper bite, and they generally come like this with this kind of an envenomation. And local manifestation is least in pit viper bites. Local swelling, bleeding, blistering, and necrosis. These are all the telltale signs of a Russell viper bite. Pain also occurs at the bite site. Severe swelling leading to compartment syndrome. Many times you can see this hand is probably having a compartment syndrome. Recently, we have come across some person who are very much used to catch the snakes as a passion, not as a profession, but as a passion. He was, bitten by this rattlesnake and had this hand to be operated on. So this is so much bad actually. So absence of peripheral pulses and hyposthesia, these are the signs. And tender enlargement of the local draining lymph node also, that happens in a vasculotoxic bite. Now coming to the bleeding part. So hematotoxic action. There are gingival bleeding, epistaxis, ecchymosis, vomiting, hematemesis, hemoptysis, even bleeding PR, subconj hemorrhage. You can see this subconj hemorrhage. Even I had a patient who had tears full of blood. He was actually shedding blood instead of tears. So bleeding from pre-existing condition, if there is a pre-existing condition, patient may bleed more. Petechiae, blebs, gangrene, these can occur, and intracranial bleeding as well, as I was telling you earlier. Gastrointestinal and retroperitoneal bleeding occurs in some patients also. And consumptive coagulopathy, those are detectable by 20 minutes whole blood clotting time. This is very, very important and diagnostic for any hematotoxic snake bite. This can develop as early as within 30 minutes from time of the bite. Now coming to the painful progressive swelling. This is a local venom toxicity by Russell's viper, Sosclil viper, and cobra. Even cobra, this you can see with the cobra bite also. So there are local necrosis, which often has a rancid smell. Limb is swollen, skin is taut, shiny, blistering, and there is a reddish kind of a fluid. You can see there, this is a reddish black fluid around the bite site. And ecchymosis due to venom action destroying the blood vessel wall. And significant painful swelling potentially involving the whole limb gradually occurs, and they may extend into the trunk. Compartment syndrome will present invariably in this kind of, you can see this leg, this is still not having a compartment syndrome, but very soon this is going to happen. Regional tender enlarged lymph node also happens. So what do the vasculotoxins do? There are hemotoxins and hemorrhagins. So coagulopathy and DIC is by hemotoxins, bleeding, acute renal failure, and hemorrhagins, they actually do an endothelial injury leading to capillary leak. Capillary leak will cause hypotension and anasarca and even go into the pulmonary edema. Later on, these kind of patients, they go into ARDS as well. Now coming to the myotoxics. These are rare in our country. So sea snakes have myotoxins in their venom. Patient presents with a muscle aches, muscle swelling, involuntary contraction of the muscles, passage of the dark brown urine because there are, muscle destruction. So myoglobinuria. Compartment syndrome again can occur. Cardiac arrhythmias due to hyperkalemia, acute kidney injury due to myoglobinuria. Subtle neuroparalytic signs also happen in the myotoxic snake bite. These are the mechanism of action. So there are depolarization, calcium influx, loss of ionic gradients, efflux of cytosolic molecules, internalization of the myotoxic phospholipase A2, all done by myotoxic phospholipase A2 mostly. So there are widespread hydrolysis of the myofibrillar proteins, actin, myosin, and removal of the cell debris. So sarcomeric disorganization, Z-line loss. Whenever you see a myotoxic muscle biopsy, you can see all those things. Occult snake bite. What do we mean by occult snake bite? These snake bites are actually, there are snake bites, but we cannot come to know that a snake has bitten. Like crate, whatever I had told earlier. So crate bite victims often present in the early morning because patients are lying down with a snake only. Because snake loves the human touch, and probably they like the smell of the human sweats. So they sleep with the human and whenever the person just turn around and the snake generally get disturbed by it and bites. So crate bite victims often present in the early morning with paralysis with no local signs. Unexplained respiratory distress, again, it's a neuroparalytic. in children in presence of ptosis or sudden onset of acute flaccid paralysis in a child or locked-in syndrome, whatever is called locked-in syndrome, are highly suspicious of a crate bite. Typical presenting history is that the patient was healthy at night and in the morning gets up with severe epigastric or umbilical pain with vomiting persisting for 3 to 4 hours, followed by a typical neuroparalytic signs. The differential diagnoses are because of the abdominal pain, the acute appendicitis, acute abdomen, stroke, but definitely acute appendicitis and acute abdomen, pancreatitis, whatever, they do not present with a neuroparalysis or flaccid paralysis. But GV syndrome will have a flaccid paralysis. But again, GV syndrome, it's a ascending paralysis. It's not a descending paralysis. Myasthenia gravis and hysteria also are differential. Life-threatening complications of a snake venom are generally hematuria, hemoglobinuria, myoglobinuria. Myoglobinuria will cause some rhabdomyolysis, oliguria, anuria, acute kidney injury. Hypotension due to hypovolemia, again, that can precipitate acute kidney injury. Acute respiratory distress syndrome or leaking syndrome and refractory shock. Pituitary insufficiency with Russell's viper. This is very, very pertinent with Russell's viper bite. Sheehan's syndrome and amenorrhea in females. So urgent resuscitation are needed in profound hypotension and shock resulting from direct cardiovascular effects of the snake venoms. So hypovolemia and release of the inflammatory vasoactive mediators that can cause this hypotension. Hemorrhagic shock also may occur. Really primary anaphylaxis. Primary anaphylaxis to snake venom occurs very rarely, but this may happen. Terminal respiratory failure from progressive neurotoxic envenoming that has led to paralysis of the respiratory muscle, compartment syndrome, renal failure, septicemia, complicating the local necrosis, because this infection may occur in that typically, the envenomation, local envenomation, and whenever there is a blister, it tends to get burst and the infections may ensue. So there is a huge ulcer later on that takes place. Poor prognostic situation are mostly this due to bleeding and paradoxical respiration and compartment syndrome. These are the life-threatening situation. In severe envenomation, early clues that the patient has a severe envenoming is identified. Snake is identified as a very dangerous one. Rapid early extension of the local swelling, and this is going beyond the more proximal joints. Early tender enlargement of the local lymph nodes, indicating the spread of venom in the lymphatic system also. And that will cause a generalized swelling of the body. Early systemic symptoms, collapse, hypotension, shock, nausea, vomiting, diarrhea. These are all systemic symptoms that may occur because of the venom. And heaviness of the eyelids, the ptosis and all, drowsiness, early ptosis, ophthalmoplegia, spontaneous systemic bleeding, passage of dark brown or black urine or myoglobinuria. These are the telltale sign of severe envenomation. Again, for the pregnant mothers, that we need to take care as early as possible. Rapid early extension of the local swelling from the site of the bite. In cobra bite on finger, necrosis may start in few minutes only. So please remove the rings and all from the hand and whatever the bangles, and mostly the tight clothings and all, those are to be removed early. Early tender enlargement of the local lymph nodes, visible signs of neurological impairment if there is. So we need to handle that aggressively. Early spontaneous systemic bleeding, especially from the gums, bite site, or epistaxis or ecchymosis. Unconsciousness, either with or without respiratory arrest, needs to be addressed properly. Passage of dark brown urine and take a look at the bitten part. Record the extent of the swelling, the extent of tenderness to palpation. Start proximally and mark it. Lymph nodes. So we need to mark this proximal part of the swelling because we need to see whether it is rapidly extending or not. Lymph nodes draining the lymph should be palpated and overlying ecchymosis and lymphatic lines noted. The bitten limb may be tensely edematous, cold, immobile, and with impalpable arterial pulses. So we need to take care of any intravascular thrombosis or a compartment syndrome. Early signs of the necrosis means blistering, demarcated darkening. These will will need to be taken care of urgently, and the paleness of the skin, loss of sensation, and smell of putrefaction, rotting flesh. That will definitely show us that this is the necrotic part that is getting necrosed actually. Then we need to plan for further amputation or whatever is needed. General examination is vitals. If there is any edema, any hemorrhage, necrosis, signs of intracranial hemorrhage is there or not, by lateralizing signs or asymmetric pupils, or if the patient is having convulsion or impaired consciousness. These are the main examination parts. Now, diagnostic is 20-minute whole blood clotting test. How to do it? A few ml of fresh venous blood is placed in a new, clean, and dry glass test tube, left at ambient temperature for 20 minutes. The glass vessel should be left undisturbed for 20 minutes in a stand and then gently tilted, not shaken. Gently tilted. If the vessel used for the test is not made of ordinary glass, or if it has been cleaned with a detergent, its wall may not stimulate the clotting. So we need to take a test tube which is not washed with any detergent, or neither this is a fresh one, and there should be no water inside it or no detergent. So this surface activation of factor 10 or Hedgeman factor, factor 11 or Hedgeman factor will not occur in a test tube which is washed with a detergent one. So we have to take a fresh dry glass. And the patient is retested every hour for the first 3 hours and then 6 hourly for next 24 hours. So if the clotting time actually, if the blood does not clot within this 20 minutes, means it's a hematotoxic bite. If it is a non-clotting, repeat 6 hours after administration of ASV. Whenever you start giving ASV, seeing this clotting time, you repeat it after giving administration of the loading dose, that is 10 vials, and thereafter as the need be. So this is how you can see the first one, the upper one, the blood has already clotted. Here, the blood didn't clot. It's still liquid. So there is a coagulopathy in this samples. There is no coagulopathy here. So what to do? We need to, if the blood is clotted, repeat hourly for 4 times and then 6 hourly for next. If the blood is not clotted, give 10 vials of AVS. This is how this is as per actually the government of West Bengal has created this protocol. And as there are lots of vasculotoxic and hematotoxic bites over here, so generally we see this at the PHC level. They do the coagulation, this WBCT test in every PHC whenever there is a snake bite patient. And blood is not clotted, so there is a coagulopathy, viper bite probable. And scenario 1, this give 10 vials of loading AVS. After 1 hour, no active bleeding, no further AVS. And then repeat WBCT after 6 hours. And if the blood is clotted, there is no coagulopathy, give 10 vial dose of AVS. Repeat 10 dose after 1 hour because this is not a hematotoxic. This is a cobra or crate bite, but patient is having neurotoxic signs. So you repeat 10 vial dose after 1 hour if no signs of improvement. So how much we are going to give, we are going to see in the next this thing. So these are the ways you evaluate. Mainly you are in the PHC, how the things are to be done. In the PHC, you can see with a peak flow meter about the respiratory paralysis, and at district hospital, you can see the prothrombin time, platelet count, clot retraction, liver function. These are the things, ECG, echo, abdominal ultrasound. And at tertiary healthcare, you can do all the tests that is needed for CPK, for myotoxic CPK, SGOT, urine myoglobin, compartment pressure, you can see. So these are the things for a tertiary healthcare center you should do for evaluation. These are the few features of envenomation for the snakes. Achha. Late onset envenoming. Patient may have a late onset envenomation, particularly in the crate. Whatever I had told that it can appear after 36 hours also. The patient should be kept under close observation for at least 24 hours. Crate and hound-nosed pit viper are known for length of time it can take for manifestation. Late onset envenoming, 6 to 12 hours in a well-documented occurrence. And in many cases, common crate bites in West Bengal, it can occur till 36 hours. Juvenile snakes, the small child snakes actually, 8 to 10 inches long, particularly in rainy season, they tend to bite the victim lower down on the foot, on the hard tissue. So the venom takes a longer time to reach the other tissues of the body. So any signs of envenomation can take much longer. So these are all about the late onset envenomation. Now, we need to do a medico-legal case initiation, MLC initiation with a local police station whenever there is a snake bite case that arrives at the primary health center. So basic, minimal and essential drugs or equipment profile are to be kept there are ABS, adrenaline, neostigmine, atropine, hydrocortisone, antihistaminics, analgesics, paracetamol, tramadol, NS bottle and antibiotics. These are the things have to be there in the primary health center. And equipments are syringes, IV set, ambu bag, mask, blood pressure monitor. These are the things. Other desirables are oxygen, laryngeal tube with laryngeal mask airway, if you cannot intubate, and nasopharyngeal airways also. So these are the things are to be kept in a snake bite kit. So this is a good snakebite management protocol that has been made by West Bengal state government. So health department. So this is how the snake bites are to be managed, but it's looked a little clumsy to me. So I had gone for this. This is better. This was as per the Government of India protocol. So overt bite, occult bite, what are the things are to be seen and how the things are to be managed. So for progressive painful swelling, viper, local necrosis, ecchymosis, ASV only. Cobra crate, the ptosis, diplopia, dysarthria, the 5Ds and all, and 2Ps, we need to give ASV. This is AN, atropine, neostigmine, and along with that, ventilation. So, and for the vasculotoxic, the Russell's viper, bleeding, demonstrable coagulopathy with the WBCT, 20 WBCT incoagulable, and shock, acute kidney injury. Here, ASV plus supportive treatment plus dialysis and blood transfusion. Again, for the myotoxic also, there are compartment syndrome generally found in the myotoxic one. So, ASV means anti-snake venom, and supportive treatment and dialysis. These are the things we are going to do in a snakebite patient whenever the snakebite patient arrives to us after the proper evaluation. Grading of envenomation: mild, moderate, severe. These are the gradings. And how much, as per the grading, the number of vials, those are needed. Maximum vials, actually, they are telling that 15 to 20, but we have given even up to 30 vials. 25 to 30 is mostly needed, and that actually reverses the venom toxins. So what is anti-snake venom? It's an immunoglobulin purified, obtained from a serum of horse, mule, or donkey, or sheep, which is immunized with the venoms of one or more species of the snakes. Mostly the big four, whatever I have discussed, are actually antidoted by this snake venom antiserum. In our country is a polyvalent one, like Russell's viper, common cobra, common crate, and saw-scaled viper. These four are taken care of by this anti-snake venom. Skin or conjunctival test for ASV has been discarded by WHO CRO guideline in 2010. So false negative skin test may make the treating doctor reluctant to keep monitoring the patient for any adverse reaction of ASV. So we need not to do this skin or conjunctival test. So sea snake or pit viper, we do not have any kind of antiserum till now. What are the indications for ASV? Systemic envenomation, hemato or neurotoxicity, hemodynamic or respiratory instability, hypotension, clinically significant bleeding, whatever we have done by the WBCT test, any evidence of local toxicity and progressive tissue swelling. Whenever you see all those, you just start loading with the ASV. What are the dosage? Like liquid, these forms, different forms are available. One is lyophilized powder and another is liquid. Lyophilized ASV is simply liquid ASV, which is frozen and dried. There is no evidence that clinically one form is better, but we can use whatever is available with the primary health center or the in the locality. So lyophilized advantage is only that it has got a long shelf life and do not require any cold chain. So it's better, available at the PHCs. The lyophilized one are available at the PHCs. And liquid needs a reconstitution. So it has to be, liquids actually have to be taken kept in the fridge or cold chain. So these are the things to be remembered. And mostly you can see the lyophilized vaccine only, which is found in the government hospitals. So now coming to the dose. Epinephrine should be drawn up before starting any ASV, because ASV has got its, to some extent, it has got an anaphylactic reaction. So we need to keep our epinephrine at hand, back of our treatment, this thing. Total required dose between 10 vials to 25 vials, as each vial neutralizes 6 milligram of Russell's viper, 6 milligrams of cobra, 4.5 milligram of crate, and 4.5 milligram of saw-scaled viper venom. Not all victims will require 25 vials. Mostly they respond to 10 to 20 vials. Patients will respond if they come in time. If the biting snake is identified to be a saw-scaled viper, 5 vials may be given as a starting dose, because the saw-scaled vipers venoms are very, very, well antidoted by this ASV. So, and otherwise, in all cases, you start with the 10 vials. For children, it's the same dose as adults. And for not only for children, it's for the pregnant ladies also. The same dose applies as adults. The range of venom injected is 5 milligram to 147 milligram by Russell's Viper. And the total required dose range between 10 and 30 vials as each vial neutralizes 6 milligram of Russell's Viper venom. So 30 vials may be required whenever the injected venom amount is, surpassing 120 milligram. Now, how do you give the ASV? Each vial of AVS should be dissolved in 10 ml of distilled water and added to an infusion medium such as normal saline. That is 10 vials of AVS dissolved in 100 ml of this normal saline and distilled water, and then added to a 400 ml of normal saline. The volume of infusion will be according to the body size and the state of hydration of the patient. In oliguria patient, restrict fluids and use infusion pump to give full dose of ASV over 30 minutes. So within over 30 minutes, 10 vials should be given. Followed by second dose of 10 vials after 1 hour, if no improvement within first hour. For vasculotoxic, you can see high dose intermittent bolus therapy can be used or low dose infusion therapy for Russell's Viper, 6 vials for Soskel Viper, and followed by 2 vials every 6 hours as infusion in 100 ml. For Soskel Vipers, the need is less. Or you can use as a high dose intermittent like 10 vials each time. The ASV can bind to a venom and it's effective against and neutralize the venom, but it cannot reverse the necrotic action of the venom or reverse the ducal swelling or reverse the renal failure or reverse coagulopathy. ASV cannot. So we need to take care of all those by proper protocols. Monitoring of patients on ASV therapy. All patients should be watched carefully for vitals, SpO2 every 5 minutes for first 30 minutes and then 15 minutes for 2 hours and manifestation or a reaction. At the earliest sign of an adverse reaction, infusion should suspend temporarily. Maintain a strict intake output chart. You have to maintain it and note the color of the urine regularly to avoid the kidney injury. Victims who arrive late, you can give this delayed administration of this 10 vials of ASV, but no more than 20 vials of ASV are needed. And if you find that ASV is not treating this neuroparalysis properly, you can use that atropine neostigmine infusion only to reverse the ptosis. In pregnancy, I have told you under the same criteria as standard victims, you can give the same standard dose. It has got a good maternal outcome. Already it has been studied in 2002. Adverse anti-snake venom reactions are mostly anaphylactic reactions, pyrogenic reactions, serum sickness type of reaction. All reactions are mediated through complement activation. Treatment of adverse reaction should be identified early, treated immediately. Drug of choice is epinephrine or adrenaline. Can be given acutely intramuscularly over deltoid or thigh, and as per the dosage that has been mentioned. Contraindications to antivenom. What are the contraindications? There is no absolute contraindication. But patients who have reacted to horse or sheep serum in the past are at high risk. So we need to take a good history on all those. And you can give subcutaneous epinephrine, intravenous antihistamines, both anti-H1 and H2. In asthmatic patients, prophylactic use of inhaled and adrenergic beta-2 agonists such as salbutamol should be taken. In severe atopic condition, give ASV only if there are signs of systemic envenoming. And injection hydrocortisone you can give for this, along with the H2 blocker. There are ways you can desensitize a patient who has been primarily reactive to the horse serum. You can desensitize fast and then give. Now, atropine neostigmine challenge test, you can give. Loading dose is the atropine 0.6 milligram IV, and in children 0.02 milligram per kg with maximum of 0.1 milligram. And neostigmine is 1.5 milligram IV stat, followed by later on, you can give 0.5 milligram IV. Step 2, it's a maintenance dose. Load with 1.5 and maintain with 0.5. There are tapering doses after 1 hour, 2 hours, 6 hours, and 12 hours. Additional management like respiratory failure, you can ventilate the patients, hypotension, fluid and vasopressors, renal failure, forced alkaline diuresis and hemodialysis, coagulation failure with FFP, cryoprecipitate, etc., whatever is needed. Infected wounds, you have to give antibiotics for management of swelling. You can manage the tissue swelling. Debridement of the necrotic tissue, release of the compartment pressure are very much needed in a compartment syndrome, followed by our rehabilitation whenever the patient is coming out of the, getting recovering. So now have come to the end of snake bites and all. Now coming to the scorpions. Scorpions are predatory arachnids. So they have 8 legs, nearly 1,000 species, and all the species have a concavity on the backside, narrow segmented tail, typical characteristic forward curve over the back, always ending with a stinger. This stinger are 2 to 4 millimeter long, and actually whenever it stings, it can deliver a good amount of venom. Nearly 1,000 species of scorpions known worldwide, and only 6 families are venomous. Mostly Buthidae. These Buthidae actually are seen in India. This Mesobuthus and Palamnius. These are this red one is a Mesobuthus and this black one is a Palamnius. You can see this tail and the stinger here. Length of average scorpion is 5 inches. Most scorpions live up to 15 years, and scorpions live in desert, rainforest, prairies, and woodlands. But we get good scorpion bites in our West Bengal also. Here, there is no desert. So there are different types of toxins. Only 25 species have venom that is deadly to humans, and low molecular weight proteins are mostly neurotoxic. They have sodium or potassium cations interfering with the neurotransmission that opens the sodium channels, depolarizes the cell membranes. Those are beta toxins. And alpha toxins inhibits deactivation of the sodium channels, thereby causing massive release of endogenous catecholamines. And that is how the neurotoxins are delivered. The caribdotoxin, iberiotoxin, and tryptophan, histamine, serotonin, those are all causing the local pain and other symptoms. TTS species has a kallikrein inhibitor causing raised bradykinin levels and definitely causing the sympathetic parasympathetic effects. Again, some TTS species can cause acute pancreatitis. Pain, which can be very intense. Positive tap test can see whenever there is you tap on the envenomation, it is tremendous extreme pain on the sting site. And edema and redness present over the 20% of cases, numbness, tingling. Mainly the cardiovascular ill effects are very much in a scorpion sting. That is tachycardia, peripheral vasoconstriction, hypertension, diaphoresis, and myocarditis also occurs. Metabolic manifestations are hyperglycemia, hyperthermia, in urinary system, urinary retention, erection, priapism in male, and in respiratory, there are bronchodilation, trachypnea, neuromuscular system, mydriasis, tremor, agitation. Cholinergic system can occur with parasympathetic nervous system stimulation, hypersecretion syndrome, salivation. Salivation is a very telltale sign of this scorpion sting. Pulmonary edema may present in 20% patient that is caused by the myocarditis. This is the local envenomation looks like.
मैम थोड़ा सा
Yes.
फास्ट कर लो अभी बस 8:40 हो
Ah,
गया.
yeah, So there are different symptoms of scorpion stings. You can see there are priapism, salivation. Post-recovery symptoms after 20 to 30 years, depletion of tissue catecholamine occurs and warm extremities, asymptomatic bradycardia. After the post-recovery, there may be some symptoms like hypotension and long QT. Generally recovers within 72 to 96 hours. Fatality occurs definitely due to ventricular arrhythmia and brain hemorrhage, pulmonary edema, multisystem organ failure. Investigations, you can see the total count. There is leukocytosis, raised CPKMB, blood calcium decreases, serum amylase increases, blood sugar potassium increases where sodium decreases, chest radiograph, pulmonary edema, and ECG is tachycardia, ventricular arrhythmia. So poor global myocardial contractility on echoes. These are the ECG findings which you can come across in scorpion bites. These are the ventricular arrhythmias that may occur, and even MI-like features, acute myocardial infarction-like features are there in the ECG. You can see that in echocardiography, there are definite myocarditic LV dilatation and LV systolic dysfunction. So how do you manage it? Local application of ice pack for the local envenomation, NSAID can be administered, and infiltration of the lignocaine for pain management. Mild systemic envenomation, NSAID for pain management, intravenous fluid, immunotherapy. Prazosin plays a definite role, is only pharmacological and physiological antidote available for the scorpion bite. There is no other pharmacological antidote. So the dose is 30 microgram per kg per dose. Dose may be repeated every 3 hours until signs of clinical improvement occurs. And midazolam for, sedation that can be taken. Life-threatening environment, grade 2 and multi-organ failure, cardiovascular symptoms. You can use intravenous nitroglycerin, intravenous dopamine, dobutamine, you can use for myocarditis induced LV failure. So these are the effects of the prazosin. You can see correction of the inotropic phase. Prazosin is the actual antidote that you can use. These actually open the calcium-dependent potassium channels, also make a coronary vasodilatation and improve the coronary perfusion. So correction of the hypokinetic phase occurs in this, like this. Some scorpion antivenom are available now, but short in supply still. Effective if patient is brought in a stage of acetylcholine excess, early stage. Total dose is 30 to 100 ml, no test dose required. So there are different stages, 0 to 4 hours, 4 to 6 hours, 6 to 10 hours. Stage 4, stage 5, more than 12 hours. How do you approach this? ASV with this is ASV's anti-sting venom, anti-scorpion venom and prazosin. These are all anti-scorpion venom with prazosin, but here you can use dobutamine for tachycardia, hypotension, pulmonary edema, and if it is required, mechanical ventilation. Where there is a massive pulmonary edema and hypertension, so you can use the sodium nitroglyceride or nitroglycerin with mechanical ventilation. And here for pulmonary edema, you can use dobutamine. So the supportive managements are oxygen, NIV, invasive ventilators, loop diuretics, oral prazosin, nitroglycerin, GIK drips, inodilator, inotropes, and L-carnitic. But here you have to avoid atropine, steroid, beta blocker, calcium channel blocker, and adrenaline and narcotics. You cannot use this. So this is all about the scorpion stings. And any question, Dr. Tapesh? Hello?
Thank you, ma'am, for the lovely presentation. Please stop share screen. And if there are any questions from the audience, we'll take the questions. Just a couple of things I want to say. First of all, scorpion bite has very severe hemodynamic complications. So it's best to
Yes.
do some kind of hemodynamic monitoring because it's really fulminant. The kind of hemodynamic changes you get are very complicated, and without some kind of hemodynamic monitoring, it becomes difficult. So that is one thing. The other things, ma'am, I just want you to highlight again how to actually give ASV in what dosing and what is the maximum dosage. I think you said 30 vials. So this is for Russell Viper also, where if there is hemorrhagic complication, and how do you decide whether the patient is improving or not? You give 10 initially, 10 vials, then another 10, then you have to repeat another 10. So these are practical
Yes.
challenges. So if you can just elaborate. Second is when to give neostigmine in neurotoxic. So that's my only question. Too, if you can just clarify for the audience.
Yes. So is there any question?
No, the audience has no question. This is my question to you. If you can just
Yeah.
clarify for the audience, how actually to go about giving ASV, maximum of 30 doses are required sometimes, how to decide, and how to decide about neostigmine.
Generally, 30 vials is the limit that you can actually give. Thereafter, it will have its own side effects. That is why the 30 vials have been, this dosage have been fixed. And patient actually may have symptoms still whenever uh, if you surpass 30 vials also, there is the 40 vials and 50 vials thereafter, they will not have any other major action on this snake venoms. So whatever venoms are to be neutralized, these 30 vials will do that. You do not need it more. So if there are other symptoms, like there is a compartment syndrome, you have to treat that. If there is a this coagulation difficulty, if there is a coagulopathy, you have to treat those coagulopathy with FFP or crapulopathy. I have already told those already. So this is how it is.
What about neostigmine? When
And
neostigmine?
yeah, neostigmine is actually, if you see, it acts only for the ptosis. This is a treatment. Atropine neostigmine is only for the correction of ptosis, as I have already told you. There is no other corrections. Neostigmine is originally used for the myasthenia gravis patients. Again, the action is the same. These are
Actually, there is some controversy, ma'am. Neostigmine does help in, if the patient is not improving. It is not only for ptosis, I think, because ultimately it improves the acetylcholine binding. So it should act at all the receptors.
yes.
Well, so anyway,
This
ma'am.
has, but generally they have, propagated this neostigmine use in neurotoxic snake bites for ptosis. They have told that.
Okay,
There
ma'am.
is definitely going to, improve some part of the respiratory muscles paralysis also, but
So just that neostigmine should be kept in mind for the audience if the patient is not improving.
exactly.
And patients generally don't improve if they come late. If they come early, then you see good improvement.
Yes,
But if they
exactly.
come late,
Yeah.
then there's a problem at times because there is denervation and all those problems. Then the actual receptors get destroyed. So, okay, ma'am,
Exactly.
thanks a lot. I think that was
Okay.
a very comprehensive lecture and you have told very nicely. And I think it will be very useful. Soon we'll put it up on the channel. Thank you so much, ma'am.
Thank you very much. Thank you very much. Good night.
Good night, dear viewers. Thank you for your patient hearing.